Okay, so today we're continuing chapter 12. Um, there will be an exam this Friday on chapters
Mhm.
9, 10, 11, and 12. Okay, so open at 4 like every week, close at midnight on Monday. All right, so I'm going to share my screen. So we're going to continue discussing treatments for mental disorders. And we last left off on biomedical treatments. One second.
Yep.
um, medical treatments, biomedical treatments, drug therapy, and so we were talking about the dangers, right? That people are being prescribed medications for disorders that they don't have, essentially. All right. Now, electroconvulsive therapy, also known as electroshock therapy, a procedure in which a brief brain seizure is induced, is still used to treat mental disorders. Absolutely. Specifically, it's most effective with depression. Electroconvulsive therapy, a procedure used in case of severe major depression. A brief brain seizure is triggered. The mood improving effect of ECT is usually short lived, and the depression almost always returns within a few weeks or months. Nonetheless, it has been shown to be effective in cases where other treatments have not been helpful. Okay, someone tell me how this works.
Well,
I want
they, oh, go
go
ahead.
back. No, mine's off
No,
topic.
no. What they do is they put a electrode on your head, and the purpose of that is so you don't bite your teeth or grind your teeth, and they give you impulses of electrical shocks, and it's supposed to stimulate the cortex of your brain, I guess.
Okay, okay.
Right?
So what is it actually doing though? You
It's
started to get to it.
it's uh, um it's supposed to, I don't know. Hammer, go ahead.
I'm I'm gonna say it's increasing the firing of neurons.
Exactly.
Yeah, yeah.
Exactly. It's causing neurons to fire. And when neurons fire, they release neurotransmitters. And that's the problem with people with major depressive disorder is that they don't have enough neurotransmitters binding to enough receptors. And by flooding these synapses, these synaptic gaps with the neurotransmitters, by shocking them awake to go puke, throw up, dump what you got. It makes people immediately feel good. Okay. But I wanted you to understand what the physical process was. What are they really doing? Hammer, do you have a question?
Sort of.
Go ahead.
With this severe major depression, they use electric shock therapy. What's the difference in the SAD where they use the light? Isn't that like another, is that just like a different form of depression or different?
Seasonal affective disorder is because we're not exposed to as much sunlight or
Mhm.
ultraviolet light. It causes our brain essentially to lower its firing rate because it's essentially messing with our sleep wake cycle, and now
Mhm.
we're awake during dark when we're used to being awake when it's light. And so as a result we become depressed because our brain is not being stimulated. So the light stimulates the brain via the, collecting through the eyes, sending it to the optic nerve to stimulate the occipital lobe, which says, hey, look at all these things you're perceiving, look at all these things that are going on, and it's stimulating globally the brain, causing neurons to fire. Does that make sense?
I, yeah, I mean, I guess I don't understand the difference between. I guess I'm having trouble understanding the difference. I have to look it back up because this is just off the top of my head, but
Go ahead.
just the SAD and the major depression, like
Major depression
diagnosing it
is year round. SAD is seasonal
just during the
and it's
winter
light
months.
dependent. Yeah.
Okay.
Yeah, that's it.
Okay.
How come it doesn't say anything in this PowerPoint about the point you made regarding the neurotransmitters? And
Mm.
you think that would be very useful information, especially on a PowerPoint, what it actually does.
Well, Bob, this is called Introduction to Psychology.
Okay.
And what I teach you guys, this is part of the reason why my course is a little difficult at times. I teach you at a 200 or sometimes a 300 level, not a 100 level. So this PowerPoint is designed to be a 100 level as an introduction where you are exposed to what is used, not how it works. I give you the how it works. I want you
So
smarter
you,
than that. I want you
so
leaving intro with more than what you are supposed to get.
okay, so it releases or it causes neurotransmitters to fire.
It causes neurons to release neurotransmitters.
Oh, okay, to release neurons to release. Yeah.
So there's another kind that's not using electricity, it's using magnetic stimulation. And the difference here is that they can target it. So it says it involves using a pulsing magnetic coil held against the person's skull over the left prefrontal cortex. There's something called deep brain stimulation. Okay. So what they're doing is implanting they're implanting a little electrode, meaning essentially a little piece of metal, into a targeted area of the brain, and then they stimulate that area. They stimulate that piece of metal, which then stimulates the neurons around it. So they can specifically target what they want, what part of the brain to fire. So, for example, patients with Parkinson's or Parkinson's disease or epilepsy, right? They're targeting specific areas of the brain. So Parkinson's, they're targeting the primary motor cortex at the back of the frontal lobe. You don't need to know that, okay? But I want you to understand the difference between electroconvulsive therapy, which is a general stimulation of the global brain, versus targeting something using deep brain stimulation. Again, using magnetic coils or using magnetism. So by giving it a magnetic pulse, essentially it's creating an electrical response in that piece of metal that's been implanted in a particular area of the brain. And so when it becomes excited, when it becomes magnetized, it becomes electric. And when it becomes electric, it shocks all the things just surrounding it. Okay. Now, go ahead, Bob. You're muted. Did you have a question, Bob? You're muted.
No, that's I found that kind of odd how they got to implant that box by your collarbone or something.
Uh-huh.
Yeah, I found that kind of invasive.
Yeah.
Really.
This is completely off topic, but would it interfere with people that have pacemakers? So I know to turn a pacer off, you gotta put a magnet on it. And something like a piece of metal, would that conflict?
I don't know, but I have to believe it would. Well, I mean, actually, maybe not. Maybe not. And here's why. Because if they're targeting a specific area of the brain, then that means it's not exciting anything outside of that area. So maybe it wouldn't. I guess it depends on where I don't know. I don't know.
Insult a cardiologist. I don't know.
Yeah. I have to call my brother. He's a cardiologist.
Really?
Yeah. Yep. He lives in Seattle. He pulls in like 700,000-800,000 a year.
Yeah. My uncle's a cardiologist in Florida. Old people.
Mm-hmm. Yeah. Yeah. Those are the money makers right there.
Mm-hmm.
Anyway. Now that we just covered the biological approach, the physical approaches to treatment of mental disorders. So what we were doing was targeting the physical functioning, the physiology of the nervous system with drugs or electricity or magnetism, how the brain actually functions. Now we're going to move on to a different kind of therapy called psychodynamic therapy. Uh, so when something's dynamic, it means it's moving, it means it's active, it means it's changing. So they're talking about a person's mental states or mental uh, states. I mean, I don't know the another way to put it. How it's changing, or how it's adapting, or how it's working, right? So psychoanalysis is analyzing the mind, a method of psychotherapy where they are analyzing the subconscious. And so what his idea was essentially is that uh, we our thoughts, feelings, and actions are a lot of it are rooted in things that we don't even know are happening, that we're not even aware of, that we have these unconscious motives and conflicts. And so his idea was, well, if we can get to the root of your fears or your desires or your wishes or your whatever, if we can get to the root of things that you're not aware of, then we can address those. And so that he would use things like free association or talk therapy or dream analysis, right? That our dreams represented something, they were symbolic. Um, and if we had a nightmare, then it represented something that we are afraid of, that maybe we weren't aware of. And we need to resolve those issues. So with talk therapy, uh, they have, the classic cartoon will show a person laying on a couch and they say, all right, now tell me about your relationship with, your mom or your dad or whatever, right? So the idea is to listen to the for the therapist to listen to the client and get an idea of key words, of key things, of key emotions or feelings, and say, no, let's talk about that a little bit more. You said that your mom was upset. When did this start? And then go on and on and on. The goal, he said, was to develop transference, where you are transferring your feelings, your uh, conflicts from the source, which could be your parents, it could be a past lover, it could be a traumatic experience, and you're transferring those things onto the therapist so the therapist can address it, right? So it's like you got a problem with your uncle, right? Your uncle, you saw your uncle kill a pig or something for a pig roast, and you didn't know it bothered you, but you always knew you didn't like your uncle, and you didn't know why. You just didn't trust him or whatever. So the idea for a therapist would be to, all right, tell me, and to get you to then transfer those negative feelings onto the therapist so you can address them. Does that make sense? So you start to look at the therapist as though they are the source of the problem. And then the therapist will try to get you to work through the problem with them as the therapist, even though they didn't do anything, right? But they go along with it intentionally.
So Freud is the one that thought of this
Yes.
transference.
Yep. Yes. Now there are also behavioral treatments, right? So behavior therapy, a form of therapy that applies principles of classical and operant conditioning to help people change self-defeating or problematic behavior. So the idea behind classical and operant conditioning is that you are learning through associations. That means that someone has a problem with a certain behavior. Maybe they pull their hair and they don't. That's trichotillomania or whatever, and they're hair chronic hair pulling and they're pulling their hair out. Right, it's a behavior disorder. You don't want that, right? So the therapist and the client develops some sort of plan, some sort of consequence to doing it, right? Something negative happens. So whenever they pull their hair, they associate it with something negative and try to decrease that kind of behavior. Meanwhile, they are also providing positive consequences for not doing it, right? So the therapist and the client create this schedule right? This daily schedule, this plan, right? And they say, okay, well, let's agree. If you can go until noon tomorrow without pulling any hair out, then uh, you can have that special thing that you want. Maybe it's a show, but you can't watch that show, your favorite show. You can't draw, you can't paint, you can't jog, you can't whatever it is that you really like to do, right? You can make it until noon, then you can spend an hour drawing or painting or walking or watching a sports show or something, right? And so there are consequences, is the idea. So exposure, essentially exposure therapy is where you have someone who, this is good for phobias or phobic disorders. So someone's afraid of heights. They say, all right, well, what are we gonna do? We're gonna expose you to it. We're gonna gradually get you up on a ladder. And they're like, there's no way you're gonna be able to do that. Sure, I can. First, I want you to stand in this book. And they're like, a book? That's like an inch thick. Yeah, just do it. All right, fine. You feel a little nervous? Kinda, but not really. All right, well, let's just stay on it until you feel absolutely nothing. All right, fine. So they stay on it for a half an hour. You feel no, actually, I don't. Nothing's happened. So what they do is they through graduated exposure, meaning they increase the level of exposure, right? So someone who's afraid of spiders, for example, all right. So they might go, all right, like I want to get rid of this fear of spiders. It's getting in the way of my everyday living. Every time I see a daddy long legs or any kind of spider, I freak out and I can't go to sleep for like 2 days. All right. So you go to the office and they say, okay, so we're gonna cure you of your fear of spiders. So the first thing they do is they have you look at pictures of spiders, right? So the first thing they do is they say, okay, so you're feeling tense? Yeah, I'm feeling really anxious looking at these spiders. I don't like this. Well, just keep looking at them. Just keep looking at them. Meanwhile, you're practicing techniques of meditation, techniques of calming yourself using, biofeedback or some sort of um, self-control techniques. So you're combating this, putting yourself back into a comfortable state, and all you're doing is looking at pictures of spiders. And then once your heart rate drops, once your respiratory rate drops, your perspiration, right, your body temperature, once you get out of that fight or flight response or reaction, they go, okay, good. So that's it for today. We'll see you tomorrow. All right, good. So you come back, you do the same thing, but now it's not as bad, right? And you do that for a little while. Then the next week, maybe they say, all right, now what I want to do is I want you to not look at pictures. I want you to look at that spider across the room in that cage. It's way over there. It's 20 feet across the room. You can see it. Just a little one. You can see it. All right. Yep. You're anxious. No, you're not going over there. It's not coming over here. Right. Practice your calming techniques. Practice that self control. Meditate. Focus on the things that you can control. Your breathing. Right. Your thinking. Okay. You do that for a week. They're calm. Everything's good. Okay. Next thing you do next week is you're going to go up 10 feet and you just gradually expose them to the thing until they're able to hold it. Now, it may take a long time. There's another thing called flooding. Flooding, an example of flooding would be where they are just put right in front of the thing that they fear the most. They go from 0 to 100. It's almost like, all right, you're afraid of spiders? Yes, I am. All right, go into that closet. They lock you in the closet and they dump a bucket of spiders on you. And
That's
literally, it's cruel, right? But people, seriously, this actually does happen. People, I don't know if it's exactly that, but they will like put a spider on the person. The person will throw up, they'll crap their pants, they'll pee, they'll cry, they lose their minds. And it takes a couple hours, but by the end of that 3 hours or whatever, that session, they're holding it. It's very traumatic.
Oh, I just crapped my
that's
pants.
Yeah, yeah, yeah. So there's systematic desensitization, right? This is what I was talking about earlier. A step-by-step process of desensitizing a client to a feared object or experience based on counter conditioning. Behavioral self-monitoring, again, a method of keeping careful data on the frequency and consequences of a behavior to be changed, identifying reinforcers and undesired behaviors. So what does that mean? It means that with the skills training, you're going to say, okay, I don't want you to pull your hair. So no, what are some triggers for you pulling your hair? Is it Coffee, then don't drink coffee as much or cut back on. Is that something that always happens just prior? Is it something related to watching the news? Is it, well, don't watch the news? Maybe it's making you anxious, right? Is it something related to school? All right, well, then don't worry about your school. Do it the night before or something. Don't do it in the morning, that kind of thing, right? So it's identifying the things that are reinforcing it. And that would be like the relief that you get, right? We'll find another way to get some relief, something constructive. It's called sublimation. And then skills training, an effort to teach a client skills or new, more constructive behaviors to replace the maladaptive ones. That's the do, instead of pulling your hair, why don't you go wash the dishes or go vacuum? So the goal behind behavior therapy in uh, in short is to teach the individual what's causing it, what are triggers, what are reinforcers, identifying what they are, teaching them new ways to cope with it using other behaviors in place. So you want to get rid of the maladaptive behaviors and put in place of those maladaptive ones adaptive ones or beneficial ones. Cognitive therapy. This is really simple. Really. What they're doing is they're asking people, it takes a while. I mean, it's not like you're going to do this in a session, to challenge the irrational thoughts, to challenge the negative ways of thinking, right? A form of therapy designed to identify and change irrational, unproductive ways of thinking, and hence to reduce negative emotions and their self defeating consequences. Have them ask things like, are my thoughts reality? As in, uh, is everyone really out to get me? Is that real? Is my life worth it? Am I worth something?
We're
Is
done.
is it hopeless?
Everything is correct.
Am I helpless?
Okay, you have to double check that. Okay.
Challenging those thoughts, getting them to seriously just ask questions. This is what we do here too. This is what you do in your college classes. This is critical thinking, questioning.
And cognitive therapy can be used for phobias as well.
Yep, yeah, but behavior therapy works the best. Exposure therapy is the number one. Yeah. Cognitive therapy is really good for people who have negative styles of thinking, who have low self-esteem, who think that the that their life, that they have no control over their lives, and that all is helpless and hopeless. The combo platter number 3 of the cognitive behavioral therapy, that's the most common form of therapy, is changing the way you think and you're changing the way you act.
Mm-hmm.
So with cognitive behavior therapy, the clients learn to explicitly identify and accept whatever negative thoughts and feelings arise without trying to eradicate them or letting them derail healthy behavior. So instead of trying to convince a patient to the fear of public speaking is irrational, accept the thought and acquire coping strategies. That is the behavioral part. That's the behavioral part. And this is more common than behavior or cognitive therapy alone. Okay. Thanks, Tosh. Family and couples therapy. They assume that the problems that people have develop in the context of the family and that they're sustained by the family dynamics and that any changes will affect the whole family. So they look for patterns of behavior across generations and create a family tree of psychologically significant events. So they're saying, essentially, they're saying, well, you know, some of the problems that you have or the problems that you have, let's see if the family has something to do with it, right? Maybe you come from a highly emotional family. Maybe it's very abusive. Maybe it's very destructive, right? And what about, let's say your parents are neglectful or something or dismissive of you, right? So you and your parents go to family therapy and they say, well, you know, Dad, you know, Bobby here is saying that, you know, you really don't pay much attention to him. Did your dad treat you with attention? Did how did your father? And typically, what they're saying, what they're finding out is that, well, dad treats whatever the son's name is the same way as his dad treated him. And so it's that pattern of child rearing, right? You see this all the time on people's Facebook posts. They're like, well, when I was a kid, yeah, and now you're the same way. Any questions?
Yeah. Well, no, that's just that for the same reason why people that their parents are on welfare, why their kids end up being and staying on welfare because that's all they know. That's what they were taught. You know what I mean?
Yeah, that
Is that
is
an example of it?
that is an example of it. That is um, that is a thing. I don't know how highly correlated it is, and I don't know that it's through the influence of the family's experience, the family's dynamics as much as it is the um, the geographical location,
Yeah.
for lack of better words.
Yeah. It's easy to make money when you have money. It's hard to.
One, yeah, that's the first part. And the second part is it's easy to have money, or it's easy to make money in some regions if there are opportunities to make money. Like you go into the cities, just look at Plattsburgh, right? Look at Plattsburgh in comparison to, I don't know, New York City. There are more opportunities in Plattsburgh than there are in New York City. You're like, well, wait a minute. The reason being is look at the number of people that live in New York City. There are not that many high paying quality jobs to sustain that city like that. So people that live in certain pockets, they run out of opportunities. They have to like branch out. So one of the things that for example, one of the things that I noticed is that my parents had 6 children, and we grew up in a very small town, uh, very small in Western New York. And I have my one brother, my oldest brother. He's the cardiologist, and he lives in Seattle. The next oldest brother lives in not in the same town, a neighboring town, but he works in Rochester. Then there's me, and I live now in northeastern New York. Then there's the brother after me who lives just like my second brother, works in Rochester. Then there's the next brother, and he lives in Maryland. And then there's my little sister, my kid sister, and she lives in Texas. So basically, what I'm saying is 4 out of 6 of us, in order for us to kind of get a job, to get an opportunity, had to go out. We had to escape because there was nothing where we were. And 6 out of 6 of us had to leave the town itself. Every single one of us. That's what I'm
Well,
saying
that's
about
what
that.
I'm probably going to end up having to do.
It is what it is. All right, I'm gonna stop sharing.
Why?